All right, so for September here, we are going to talk about the respiratory poisons. And a lot of it does have to deal with the hazmat and different types of chemicals that a person can go ahead and inhale and end up having issues with. So we're going to do a review a little bit about anatomy and physiology, talk about some of the common household poisons and cyanide, and a little bit about capnography at the end. So, all right, when we take a look at the lungs here, where we look, there's a difference between the actual ventilations and respirations. Ventilations, we're looking at gas exchange actually occurring. It's more of a passive type. Respirations are actually where you're physically, inhaling and exhaling, and that's what we actually count when we look at someone's respiratory rate here. But when we look at the different, how it kind of goes down and works to the alveoli, anytime there's damage to this alveoli, we can have a problem. We have that ventilation perfusion mismatch, and meaning that we're either not getting enough oxygen to this area, it's being blocked from diffusing across the alveoli into the alveolar capillaries, or there's not enough perfusion going through or blood supply going by the alveoli to take the oxygen where it actually needs to be. So we consider anything in the upper airway, anything above the vocal cords. Most of the time what we see here is injury due to a traumatic process, burns to the face, superheated air, steam, those types of injuries we'll see with the upper airway. In the lower airway, this is when a lot of the times the chemicals get down deep into the alveoli itself, and it can damage the alveoli, or it can just actually not have enough oxygen for the alveoli to go ahead and have that gas exchange actually occur. I like this slide here because it kind of talks here. You can see each one of these little alveoli, it has the alveolar capillaries across. So when we breathe in, air comes in, it diffuses across the membrane into the vascular system, off to the rest of the body. Then when it comes back, it has the CO2, which diffuses back into the alveoli, and we go ahead and exhale out. And that's why when we're using our end-tidal CO2, it's really important to make sure that where someone's at as far as the amount of carbon dioxide a patient is exhaling, in order to be able to determine are they truly metabolizing like they should. So when we go ahead and we breathe in, our diaphragm pulls down, air rushes into our lungs. When we go ahead and relax and the diaphragm goes back out, or goes up, air rushes out. We look at a couple different things as far as ways to help. Mainly you guys use the CPAP. BiPAP is used pre-hospital also, but not in our areas. And then using the bag valve mask. These are all different ways to increase the positive pressure of ventilation that we would be able to assist the patient with. Now, one thing we have to really be concerned about when we start using CPAP or a bag valve mask is we have to be concerned about the preload coming back to the heart. CPAP, BiPAP, bag valve mask, they can also go ahead and decrease the preload back to the heart, meaning that the air in the lungs is filling up too much that it's not allowing circulation to actually occur, blood to return back to the heart like it should. Now there's a couple different types of hypoxia that we're going to kind of go through. First is stagnant. You've got someone in cardiac arrest. Blood is just stagnant there. It's not flowing. It's not going anywhere. Therefore, gas exchange cannot occur. This is not only a ventilation issue, it's also a perfusion issue. And that's what we call stagnant hypoxia. Hypoxic hypoxia means that a patient isn't getting enough oxygen into their lungs. And we see this a lot of times with patients that have COPD or even have respiratory depression. Anemic hypoxia, this is more of a cellular issue, meaning that there's not enough red blood cells or hemoglobin for oxygen to go ahead and attach itself to go through the rest of the body. And so when a patient doesn't have enough red blood cells, it still will go ahead and decrease the amount of oxygen that is delivered to those end organs. And then histotoxic hypoxia, this is where some of our blood cells are not functioning like they should. They're malformed, they could be from sickle cell, it could be from CO poisoning, cyanide poisoning, but bottom line, the actual hemoglobin cannot accept the oxygen molecules. So it breaks down pretty nice. When you talk about stagnant, the lungs are working like they should, but the heart isn't. It's not doing what it's supposed to do, so it can't circulate the blood. So that's mostly a perfusion issue. Cells are real good. They're functioning like they should. Hypoxia, lungs are not working. You're not getting enough oxygen into those lungs. Heart's doing what it's supposed to. Blood is circulating, and that provides one of those ventilation perfusion mismatches. And then cells also are in good shape. Now if you look at anemic and histotoxic, they're both the same. Lungs and heart are doing what they're supposed to, but the cells are not. And so therefore someone becomes hypoxic because they can't attach oxygen to the hemoglobin. When we start assessing patients, a lot of times we get tunnel vision. We hear wheezes, for an example, and automatically someone says, well, if they're wheezing, I've automatically got to go ahead and give them albuterol and Atrovent. We've got to take a look at the whole big picture, what's really truly going on with our patient. We have these main 4 different types of lung sounds here, but you have to take a look at their history. Have they been feeling crappy for the last couple days? What was their history beforehand? Do they have an airway obstruction? So if we have rales in a patient, most of the time we think of fluid in the lungs. But knowing that fluid in the lungs is mostly in those lower lobes. It's fine, it's got a crackle sound, sometimes sounds like Rice Krispies. Usually means that we have fluid down in the deep in the alveoli. We see this a lot of times in our heart failure patients and in even patients that have pneumonia. I'll explain in a second. Bronchi, this occurs in the larger airways, more up above. And this has the accumulation of mucus or other fluids in those larger airways. We can say it sounds thick, it sounds coarse, and we see this one in COPD or pneumonia. So again, we've got 2 different lung sounds, both indicating possible pneumonia. And we have to go back and take a look at our history to say what's really truly going on in order to appropriately diagnose them. We go ahead and we hear rales and we give a patient with rales, or who's in, we think CHF, Lasix. It can be very detrimental to this patient that has pneumonia because it's going to go ahead and dehydrate some of the infection or mucus that might be in those alveoli, turning it almost to like a cement type gunk that is very difficult for the lungs to go ahead and get rid of. Wheezing, we can hear in asthma and bronchitis, and we can hear those in all different fields. If you take a look between rales and wheezing, take someone who's got heart failure. They go ahead and they're sitting bolt upright, 6 o'clock in the morning, telling you they can't breathe. We go listen to them and we can hear the rales from across the room. But when we start listening to lung sounds, up above we hear wheezes. So we think, wheezes, I've got to go ahead and give albuterol and Atrovent. I've got to bronchodilate, get air movement. But that can be very detrimental to those patients. The best thing here is to actually go ahead and put them on your end tidal. Water and air will go ahead and, or CO2 will diffuse through water and air just like a normal, either one. But your waveform is going to tell you the difference between is it cardiac related or is it truly respiratory. Because if it's the asthma, bronchitis, you're going to see that sharp fin. If it's truly CHF, it should be a normal waveform. You give albuterol to a patient who's in CHF, their heart's already failing, not doing well. And so you're going to actually cause that heart to have more problems and actually maybe cause some ischemia in the meantime. And then finally the stridor. This is mainly heard over the tracheal area and the upper airways. We hear this a lot of times when we have a foreign body airway obstruction or even something where the airway starts to close up. Burns, superheated air burns to their oral pharynx. So here are some of the poisons we'll start talking about. Mixing of these common household items. I kind of have to laugh because one of the firehouses, they were trying to clean out the showers and he went and was using ammonia to go ahead and do so. And then he was also using some muriatic acid to clean out the showers, and they decided to pour bleach all over it too, on top of it. Put a nice cloud in the firehouse, and they had to use fans for a couple days in order to get the smell out of it. But it could have been a serious problem had they been overcome by the fumes. So sodium hypochlorite, which actually is a quiz question, is our main active ingredient in bleach. When it goes ahead and mixes with anything with ammonia, window cleaners, pet urine, human urine, even some of the paints, it can cause quite a cloud or a gas. Mixing some of these household cleaners with different acids, vinegar, dishwasher detergents, some of them drain cleaners, that CLR that they show on TV, and then the brick and concrete cleaners can also cause a nice little gas. So if we mix bleach with acid, we get that nice chlorine gas. It's going to cause the airway to be irritated. Sometimes respiratory distress, you're going to have a little bit difficult time breathing. Runny nose, maybe even some pulmonary edema, and if it's at very high levels, could ultimately lead to death. If we mix bleach with ammonias, another type of toxic gas is produced. This can also go ahead and cause shortness of breath, chest pain, wheezing, but regardless, both of them are going to cause respiratory issues. Unfortunately, there is no antidote. The only thing we can do for these patients that do go ahead and mix these chemicals together is to get them out of the area, get them into fresh, clean air. But your safety is going to be a big concern too. We always tell you guys that if you ever suspect anything, you smell something, something doesn't seem quite right, back out, get yourself out of the area, and then get the proper teams to go ahead and take over. If your patient has a lot of contaminants on their clothing, they should have their clothes removed and they need to be decontaminated. Now at the BLS level, there's not a whole lot they can do. They can decontaminate them, they can give them oxygen, get them out of the area, and that's about the extent of it. They can monitor for any wheezes or pulmonary edema. At the ALS level, we may need to contact medical control to see if we can use CPAP, but more than likely these patients are going to need to be intubated. Deep down in the alveoli is where the problem is. They can't have gas exchange actually occurring. And that you might see wheezing and pulmonary edema also there. Some of the other things, pesticides, the organophosphates and the carbamates, mainly we worry about these at the skin level or absorption level. But in certain situations like farms, I think they can go ahead as they're spraying on their fields, they can end up having them inhaled. Areas like greenhouses that are poorly ventilated, they can go ahead and have issues too of ventilation problems. Now this is going to cause airway problems, but it's also going to go ahead and cause that sludge, that salivation, lacrimation, urination, defecation, GI issues, emesis, that are going to cause these patients to be a big problem for you. Now, it may cause burns to the airway itself, and it does get absorbed down into the alveoli, so gas exchange is very difficult to take over here. People that are, prone to it or around it a lot, over time they can have it build up in their system. They get very small doses from chronic exposure. Again, farmers, those that work in greenhouses or flower houses. Paraquat is another widely used herbicide that they use. Even small amounts can cause problems. Large amounts, one sip can go ahead and kill you. So if you're looking to kill someone, that's probably a good way to do it. Unfortunately, there's no antidote for this. Okay. With the organophosphates, just to kind of go back here, what do you guys have that could be a benefit to organophosphates or helpful? Atropine, yeah. Do you guys carry enough? No. No, we don't. Even some of the things too that can be used, we'll talk a little bit later about the nerve agents for these atropine can be, because it's that anticholinergic which basically dries everything out. All right, byproducts of combustion. like I said before, you guys know a lot more about this than I do as far as different things that are found in fires that catch fire and the toxins that they go ahead and produce. But couches, really anything that can burn in a house now is going to cause some type of toxic gas. If it's not smoke inhalation, it can be some other type of cyanide gas that can occur. And these have the same effects as nerve agents. Other things too, spray on polyurethane, on wood, cement, steel, aluminum. The insulation. Now, I've heard so many different things about the insulation, maybe you can enlighten me. This insulation, once it cures, does it actually burn or does it snuff out?
Anything will burn it.
I know. Yeah, as you can see, he's well protected as he's going ahead and applying it, but once it cures, it should be fine. You shouldn't have any problems unless, like I said, you end up with some type of fire. Now, this exposure can actually lead to sensitization, meaning that the first time, probably not anything that's going to happen or nothing big at that matter, but each time they're exposed after that, the next time could be an asthma attack, and the next time something worse for it. Some of the triggers are going to be pulmonary edema or even bronchial constriction for these patients. If we have a patient who is suspected of cyanide poisoning, and that goes for you guys also, I mean, we told you guys over and over, we talked last week about the cyano kits in the protocol book. The hospitals do have them. If you suspect that one of your patients may have cyanide poisoning, or one of your providers might have cyanide poisoning, letting the hospital know as soon as possible. We used to have amyl nitrate that we would go ahead and break open and put in the oxygen mask. But the thing about the amyl nitrate is if you use that, then you can't use the cyano kits. So we pretty much just sticking with the cyano kits. Some of the signs and symptoms: altered mental status, confusion, disorientation, not really understanding what's going on. You might see some soot around the mouth, might indicate some type of burn injuries, mouth or nose. And then they've been in an enclosed area where they've inhaled smoke. Now, cyanide poisoning, it's a byproduct of fire, or the byproduct of fire is the hydrogen cyanide, and this actually can be used as a chemical weapon. Some of the things they do. Small amounts in our bodies can handle. It goes ahead and it can be combined to make B12, which our body just will go ahead and excrete through urine. And we use B12 to actually help maintain healthy nerve and blood cells. In our large doses, our bodies become overwhelmed real quick. The cyanide attaches to the hemoglobin, even more so, not as much as CO2, but more so, I think it's 35 times more so than oxygen molecules. And oxygen cannot attach to those hemoglobin, thus providing the end organs in our cells and tissues the oxygen it needs. So it basically suffocates the body. Some of the other signs and symptoms: generalized weakness, confusion, behavior that's kind of off the charts, headache, dizziness, vomiting, abdominal pain, and ultimately seizures. Depends on how much you're exposed to, and in what quantity and in what area, how much ventilation there actually is. So when it's inhaled, people can lose consciousness within 30 seconds, apnea 3 to 5, and go into cardiac arrest in 5 to 8 minutes. Now, they put a whole bunch of these videos in here about the different club fires and that. They're just news clips of it, so I actually didn't show them. I showed them one time, and I didn't really show them after that because they really didn't have anything that was worthwhile in them. But the one, the Station Club nightclub fire, within 90 seconds, people had started to lose their lives because the place had just gone up in smoke. They lost over 100 people. So what do we do for these patients? Well, we got to get them out of the area. We've got to get them into fresh, clean air. If we suspect that it's smoke or carbon monoxide, sometimes we'll go ahead and send those patients to hyperbaric chambers. Try and recognize the signs and symptoms. Let the hospitals know immediately so that they can get the cyano kits ready to go. Get them intubated as soon as possible. And that goes even for those that have possible burned airways from smoke inhalation or even superheated air or whatever. If we can get them intubated before the airway goes ahead and swells up, the patient has a better chance of surviving. Once that airway swells up, the likelihood of you getting them intubated is pretty thin. So in our cyano kit, you're going to see there's a couple different things. The vitamin B12, and this combines with the cyanide in the blood and allows the hemoglobin to actually carry the oxygen again. And then a synthetic vitamin B12 is then formed and it is excreted through the urine. So this is kind of, we give the cyano kit, it combines with the cyanide, creates the synthetic B, and it releases oxygen into the cells, and then the body gets rid of it. If you take a look at some of the side effects from it, day 1 you can see she's pretty red, you know, and then but by day 8 she's back to a normal color again. But yeah, that cyano kit will turn a patient pretty red. It's that time of year where you guys, if you probably haven't realized, have been responding to more carbon monoxide detectors going off. You know, we're starting to go ahead and fire up the furnaces. You know, people that don't have the heat, they're using kerosene heaters in their homes, fireplaces, wood-burning stoves, things like that. Their ovens, their gas ovens, they're using those to heat their house. But anytime, you can go ahead and have the carbon monoxide. Do you guys have the RAD57s, which goes on the fingertip to determine the percentage? Yeah, most places actually do right now. So carbon monoxide has an affinity of 200 times that of oxygen, and it will attach to the hemoglobin. It doesn't allow oxygen to attach, therefore those end tissues get suffocated because they cannot receive the oxygen. These patients ultimately need to go to a hyperbaric chamber, and what Lutheran has one. I'm trying to think who else has the hyperbaric chambers around here.
Tony has one, I think.
Weiss has one too.
He used to work at Swedish, so
Nice.
rid of it, and I think he's got one now.
Okay. Yeah, and I'm talking about the ones that you use to get rid of your hangovers the next morning, but. So yeah, we have those that you can go ahead and transport patients to. Usually take them to the closest facility. The hospitals will make the determination where to go ahead and transport them to from there. So. Some of the signs and symptoms, headache, dizziness. If you take a look at our protocol, I think our protocol's coming up here, but take a look at our protocol. It basically tells you which signs and symptoms and what percentage of carbon monoxide the body is going to be having at that time to make the determination. But yeah, be prepared for cardiac arrhythmias, shortness of breath, flu-like symptoms. Now, if you go to a home where just one person has flu-like symptoms, it may not be carbon monoxide. The whole household has flu-like symptoms, everybody that's been living there. Yeah, we had one the other day that they had 3 kids and mom and dad. Mom and dad were perfectly fine, but all 3 kids were having flu-like symptoms, and the carbon monoxide detector started going off. They transferred them up to Children's, and they ended up in the hyperbaric chamber. Parents didn't. They had lower levels of carbon monoxide in their system. And you can see here too, based on the parts per million, you know, what kind of signs and symptoms. 800 dizzy, nausea, convulsions within 45 minutes. So, the only thing we can do pre-hospital for them, get them out of the area, give them high flow O2, use some positive pressure ventilation, and then get them to somewhere where they can go to the hyperbaric chamber. Here's another, this one was where the electrical fire in Westchester, 5 firefighters were hospitalized due to smoke inhalation. And here's our carbon monoxide SOP. And like I said, it really is not a big SOP. It just tells you give oxygen, watch for vomiting. And then here's your percentages and what signs and symptoms you would expect to have. Remember, with carbon monoxide, your pulse oximetry is not going to be effective. Your end tidal, though, would probably be a good idea. Some of the other things to take a look at, confined space rescue. Confined space rescue, generally we have separate teams for these types of rescues that they can go ahead and do. You know, whether they're down in sewer holes or in smaller areas, some of the things we worry about, you know, any chemicals or vapors or gases that may be in the air. The likelihood that you have a lot of room to do anything, to treat any patients, can be very difficult too. These are areas generally not designed for people, you know, tanks, vessels, silo grain elevators, manholes, and pits. Now, we worry about with confined spaces, mainly we start off with the oxygen concentration. Anything with 19% or less can be harmful, and anything greater than 23% can be harmful. The other things, other flammable gases or toxic gases, need to make sure that you have proper ventilation or you're wearing the proper equipment in order to go into some of these areas. If our oxygen, as you can see here by percent, 10 to 12%, respirations further increase in rate and depth. Poor judgment, they start to get blue lips. If we have 4 to 6% oxygen, coma within 40 seconds, convulsions, respirations cease, and ultimately leads to death. Anything greater than the 23.5 can be extreme fire hazard for these patients. And again, this chart here you probably know more about than I do. I'm not even going to go into it a whole lot, but it talks about the different gases in some of these patients. Hydrogen sulfide exposure, parts per million. If you're at 10 parts per million over 8 hours, that's pretty good. I mean, no one's going to worry too much. But if we're up near 200 to 300 parts per million for an hour, you might have eye or respiratory irritations. Anything higher than that, minutes, up over 1,000, unconscious, could lead to death. Now, some of these may have the rotten egg smell at low concentration. At high concentrations, you may have no idea what's going on. This article was about the worker that was down in the manhole cover, or in a manhole. He actually had gone down to do some work. He didn't come back, so someone else had gone down there and helped, and they overcame by the toxic gases. And they had called fire and rescue. Firefighter went down there and overcame by the toxic gases, and they were all killed in this confined space incident. Okay. So they were overcome by gases and the low oxygen concentration. So the oxygen levels were only 11% in that sewer that they were working. So making sure again you're using the proper gear. Yeah, and here too, another situation where a firefighter was injured critically when they were trying to save 3 men who died in a manhole incident because of the toxic gases. Let's see here, had methane and hydrogen sulfide coming out of the 15 feet deep hole, and within seconds the firefighter was also come over by the poisonous gas and was in the hospital fighting for their lives. So you are dispatched to the scene of a structure fire. You are the recipient of the victim that was removed from the structure. The patient was found in the second story unresponsive. You note the patient is unresponsive with a GCS of 3 and breathing 6 times per minute. Just by looking at him, what's your major concern with this guy? Airway, yeah. So you can see looking around the mouth, he's got some soot around his mouth and his nose. Okay. What care do you want to start off with for this guy? Yeah, giving him oxygen, maybe even getting him intubated, if at all possible. So you secure the airway. As far as the capnography, what would you expect to see as the capnography? Normal waveform, high numbers, low numbers? Remember, it's measuring the carbon dioxide the patient is exhaling, right? Okay. You would expect to see higher end tidal numbers with this patient. What kind of signs and symptoms would you expect to see if we had cyanide poisoning? Maybe confusion. You know, he's already unresponsive, but if he was awake, if he's confused, any bizarre behavior, headache, would you go ahead and call this in if he had just been overcome by smoke with cyanide also? Yeah, there'd be nothing wrong with letting the hospital know that you suspect possible cyanide poisoning for that patient. Okay. Yeah, I don't think that's less than legal. So we got CN gas and CS gas. CN gas is the active ingredient in mace, mostly used by police and military to control riots. Less utilized due to the higher toxicity. With CS gas, it was first utilized in 1950s for also the control of riots. This is more widely used. It's 10 times more stronger than CN gas, but it's less toxic. CS gas affects within 30 seconds and can last for up to a half hour. Now, mainly when we see these types of patients, they're having the runny eyes, eyes are irritated, maybe the mouth, the nose, even the skin can be irritated. What's the only thing we can do for patients that have been affected by this? Yeah, water and give them air, and that's clean air. Some of the other things they might have, nausea, vomiting, blistering of the skin, hypersalivation, kind of goes back to that sludge again, the salivation, lacrimation, urination, defecation, pulmonary edema, and it can be extremely fatal in high doses. So the only thing we can do for them is get them out of the area where the gases are, maybe rinse the eyes, rinse the skin, if that's what seems to be their problem or their irritant at the moment. Watch for signs and symptoms of wheezing or even pulmonary edema, and transport these patients. Make sure we're decontaminating them if we can before you get them in the back of the ambulance. You know, if they're still covered in it, you don't want them in the back with you. Some of the nerve agents, chemical warfare, the effects of the nerve agent can affect many different things, and it really depends. They're very similar to the organophosphates. And that's why we use the atropine and the 2-PAM as our part of our duodose for these. Most exposure routes is going to be the eyes, the skin, and the respiratory tract. And each one depends on how long you've been exposed. So if we're looking through the air, it can come in contact with their skin, their eyes, or they can even inhale it. It can come in contamination by way of food and water, and even clothing. It is heavier than air, so it's going to be at a lower level. With these patients, how long they've been exposed is going to really determine how bad the symptoms actually are. Symptoms can appear within minutes, you know, or seconds to minutes, depending on how they were exposed. And it can have a toxic effect or a cholinergic effect. So it can affect the parasympathetic nervous system. Basically, when they are, the parasympathetic system goes into overdrive at that point in time. And that's why we have the running of the eyes, the running of the mouth, the nose. The heart goes, gallbladder, the intestinal drive, stomach, colon, bladder. And so the only thing that we can go ahead at that point in time is give them the atropine. Yeah, they've actually added BAM onto the end of it. Bradycardia, abdominal pain, pinpoint pupils, and muscle fasciculations. So our Mark 1 kits, they're so expired, and I know the government, after they administered or gave you guys the duodose, they pretty much said you can get rid of the Mark 1 kits. But the duodose contain one medication or two medications in one auto-injector, and it's going to be the atropine and the 2-PAM. Now, I believe yours, I don't know where your hazmat truck is, I can't remember where yours is right now, but you do need them. The hospital has them too. All the hospitals have a set for EMS, and they have a set for the hospital for your patients. The atropine is going to be your anticholinergic, stops the overstimulation of the parasympathetic nervous system, and the 2-PAM is mainly used to regenerate the receptors. Now, our time frame for treatment in certain areas is Solomon. have to treat within 2 minutes, otherwise most of the time they're gonna be dead. Other nerve agents you can treat within 5 hours, and VX over 40 hours. And that's what this was the old Mark 1 kit, came with